So we are recording this session, and you will be uh, it will be sent out directly, or well, not directly after this webinar finishes, because I just have to wait for downloads and processes. If you have been forwarded this link and you haven't booked through our website, please leave your email in the chat to make sure that you receive all of the resources that will follow. So I'm going to hand over directly now to Kate to introduce herself. Kate, welcome from South East Coast Ambulance Trust, and for supporting this session today for our care providers around contacting NHS 999 and 111. So over to you, Kate.
Thank you. Thank you everyone for joining. My name is Kate Mackney. I am a Strategic Partnership Manager for Sussex within South East Coast Ambulance Service. And I also hold the role of a Programme Manager and lead on our virtual care space. So the presentation today kind of hits every marker that I can inform you on. I will run through some slides and then happy to open for questions. But thank you to those who've been able to join and for all the work that you do every day for residents and patients within the Sussex area. Today's session is to explain how we can support and how you can support as care providers the ambulance service during periods of increased system pressure. I'm going to help you hopefully to try and understand when to contact 999, when to contact 111, what information our clinicians require to make those sort of safe, timely decisions. But I wanted to remind everyone that the decisions that we make within the Ambulance Trust and where we navigate and direct patients to is not about withholding care when we choose maybe not to send an ambulance or to refer you to a different signpost, but it's just about getting the right care first time and protecting our emergency capacity for patients that have that immediate risk and sort of keeping our systems safe. So hopefully by the end of this session, you'll be clear on how to route contacts correctly, the minimum information that our clinicians require, how you can engage more with our virtual care responses, and then your role as providers in reducing avoidable ambulance dispatch and unnecessary ED attendance. Sometimes our expectation is that calls come in and we give high quality structured information so that we can really differentiate that risk and navigate you safely through the pathways. I'm sure you're all as busy as we are with increased system pressures, but the winter months bring consistently higher demand across urgent and emergency care systems. December is typically the peak for 999 call volumes, and it's usually driven by those seasonal illnesses that you probably all see: flu, COVID, respiratory infections, and cold-related injuries, and sometimes those exacerbation of long-term conditions. During these periods, every avoidable contact and every incomplete handover directly affects CCAM's ability to prioritise our life-threatening emergencies. So where the expectation can be that an ambulance response is required, we really try to choose the appropriate route and provide complete clinical, concise risk information, and then that's how we can keep our response times safe for those at immediate risk. During December last year, CCAM managed 72,945 total incidents in that 1 month. Around 17% of those were safely resolved through a hear and treat, so via a telephone clinical assessment. 83% of them received an ambulance response, and 36% of those that received a response were either treated or reassured at scene with no onward transport. So we did still have a high conveyance to emergency departments of 64%, and some of those did include same-day emergency care spaces or urgent treatment centres. What this tells us is a meaningful proportion of cases reaching CCAM can be safely managed without necessarily conveying a patient. And when we receive accurate and complete information at the start of calls, sometimes the information could be limited or unclear, and I completely understand that. As you say, we've got a variety of patients under care and also lots of different duties and objectives and priorities for the day. But it's more likely that we'll dispatch if that happens, just to manage the risk. So your input up front can help directly shape that clinical pathway and support the patient to the right care. I'm not sure if all of you are aware of this, but CCAM has a 5-year trust strategy, and it is aligned to the long-term NHS vision. It directly informs how 999 and 111 can operate today, and we really link into those hospital to community, so care closer to home wherever it's safe, that analog to digital space. So looking at our virtual assessment again, it's a core um, part of our emergency model. And we'll also look to sickness and prevention. So we try to be proactive in that space to prevent either repeat callers or prevent repeat presentations and approaches. Not every 999 call, as I said, will or should result in an ambulance dispatch. It is our responsibility to deploy the right response the first time. And as care providers, you can help us differentiate that risk accurately and as early as possible. So for us, virtual care is starting to emerge as a standard emergency response. And as I said before, it's not a delay or a fallback, but through structured clinical questioning and access to care plans, all clinicians and our clinicians can assess remotely. They can provide clinical advice and reassurance. They can refer into community or urgent and care services. And they can also still dispatch an ambulance where clinically necessary. In many situations, virtual care is clinically safer and faster than waiting for a physical response. Um, be prepared to engage with vital clinical assessments as it is integral to how CCAM can respond to the patient's need and to keep our patients safe. So how as providers can you help? When you contact CCAM, either through our 111 or our 999 service, it is the the minimum information that is required for our clinicians to safely differentiate care. So care planning, any up-to-date care plans, including escalation guidance, and today's observations are really important as well. So what are their normal observations? Is there anything different, any change in their vitals for the patient? The status checks of things like DNA CPRs or treatment escalation plans are really important. With limited access to shared care records and information via our CAD, and obviously, if a call comes into 999, it's seen that every call comes in that is an emergency. So, having that information available for us would really help support any actions that we take to patients as they're presented. And where possible, any baseline presentations, as I said, what is normal for the patient and what is today's change. If this information is not available, and I do understand that that can happen, it can sometimes limit our ability to avoid dispatch and may increase our conveyance, as I said before, to manage that risk and to ensure that the patient is safely supported. Um, just bear in mind, we have choosing the right service there. So 999 for immediate risk to life, time critical emergencies. So anything like chest pain, severe breathlessness, major trauma, stroke symptoms. Our 111 service, either via the phone or online, can support for urgent but non-life threatening issues, still requiring clinical advice or referral. And again, you can sometimes end in an ambulance response or an ED referral. And we're really working hard within our virtual care space to ensure that we can flow the pathways and get the patient the right route. And obviously, you can use our 111 service as well for any GP or pharmacist questions, medication queries out of hours, etc. Routine, non-urgent concerns can be followed up by their own GPs. If you were to look at a call structure as a third party, sometimes it is difficult to convey information. So it is important, as I said, to structure that call. So, as you say, I'm sure you all do this, introducing yourself as the care provider or the carer or the home, having the details of the residents, patient's date of birth, presenting symptoms, again, how it was different. Today we observed ABC. DNA CPR yes or no, escalation plans are XXX. We're requesting this information for it to will support the clinical assessment and whatever the outcome is based on that risk and red flags, and have your care plans available. So this structure saves precious minutes and, as I say, can reduce unnecessary dispatch. Avoidable calls don't just affect CCAM, they can delay responses for cardiac arrest, stroke, major trauma, etc., and can materially reduce our avoidable contact by as we said before, having those preventative actions, ordering repeat prescriptions early. We do have that application through our 111 service as well, for emergency prescriptions, monitoring vulnerable patients. I'm sure you do that all day long, especially in this cold weather, for your residents, and also keeping documentation clear and escalation plans current. Um, Using 111 services early for advice can sometimes support not always defaulting to 999 when the risk is not life-threatening, and again, providing concise information. Um, Virtual care advice will be available should we feel that a virtual response is necessary, and that can support you, again, avoid dispatch where it's not clinically indicated that one is needed. So, key messages. Winter pressures are a shared responsibility. We understand that, and we understand everybody is under pressure and incredibly busy. Using the right route first time and providing complete and structured information will improve the outcomes for all providers and for CCAM. Virtual care, as said as before, is a key part of CCAM's emergency response now, and not every 999 call will result in an ambulance dispatch. And for providers, your role in early accurate differentiation protects emergency capacity for those who need it the most. We thank you for your partnership. It genuinely saves lives. We have key care home leads that work within our systems as well. So happy to link in with those to support your needs and what your individual requirements are better. Happy to take questions. I also have my colleague Waz here with me who's joined. He's one of our practice development leads. So if the question is better placed in a scenario that we want to walk through, or if there's a fall or a head injury, say that needs answering, I might join him in as he has far more clinical information than I do. But we can do our best to show you how routing information and quality will change that outcome for your patients and also to support our demand needs. Thank you.
Thank you very much, Kate. Very insightful. While people are thinking about any questions that they may have, can I just touch on, there's a couple of things I noted down. Um, Certainly to have the details for those key care home leads, I think across the patch that will be really helpful. So if we do receive any inquiries, then we can signpost appropriately. And I'll come back to my other one because Colin's put his hand up. So I'll hand over to Colin for his question. Colin, over to you.
Hi, Kate. Thank you for that. Very informative. But you said within your presentation that the processes are not about delaying care.
Mhm.
From a care home manager point of view, I find they do delay care. If I give you an example, we phoned for an ambulance prior to Christmas, got told it didn't meet the criteria, so we'd have a clinician phone.
Mhm.
It took over an hour for the clinician to phone, so we provided exactly the same information to the clinician that we provided to the 999 service. They said they would need to go and speak to someone else. 35 minutes later, they came back and said that another clinician would phone us. We
Mhm.
then had to provide that information again to another clinician. And probably about 2.5 hours later, we got an ambulance for this client.
Understood. And again, it's not the first time I've had that experience, and I apologize that you guys had to go through that. Probably in a time, as you say, of peak demand for everybody. We are in CCAM working really hard to improve that. So we're looking at clinical assessment hubs and supporting with remote clinical assessment better. And one of our most achievable objectives is going to be to have like a single response. So we're not constantly, not just for providers, but we're not constantly ringing patients back, as you say, re-triaging, getting more information, having to confirm details, that there will be one flow right the way through that where you'll have a triage. The individual will be navigated as to whether or not what sort of response is required. If it is a clinical assessment response, it will be one response, and then we will have that sort of outcome dispatch signpost, etc. So as I say, it's not the first time I've heard that story, and I apologise for you having to go through it, but we are working harder to ensure that we can get it right first time. And as you say, working with providers that if we get all the information right in on that initial call, you too should be able to flow through our system better.
Thank you.
Did you want to respond, Colin? Are you okay?
No, as long as things are being put in place to try and resolve it, because
Mm,
I would say, especially for a manager, it is our biggest issue if we're trying to seek that support and we're having to repeat and repeat and repeat the information we're
mm,
providing.
Mm,
Sometimes I'm worried that that information will get lost somewhere in the system.
mm. And as you say, with the response that you achieved at the end, it may have been that it passed our risk assessment deadlines or passed our, initial ability to hold that call to get you a signposted response. So an ambulance was dispatched to mitigate the risk, um, which isn't ideal. But as you say, eventually a care provision was provided. So it's those sort of things that we really need to look at and work harder on and ensure we can flow patients through better.
Thank you.
and Kate, Wasim's got their hand up, so over
Thank
to
you.
you,
Can you hear
Wasim.
me? Can you hear me? That's always
Yes.
it's the first challenge. Sorry, it took me about a minute to find the hand button. Colin, hi. Like Kate said, I'm sorry that you didn't have such a good experience. Can I ask, whereabouts is your care home?
We're in Peacehaven.
Peacehaven, okay. And do you remember what day you called? As in, was it a weekday or a weekend?
It was a weekday.
It was a weekday. Okay, so in Brighton, Peacehaven covers Brighton. We've got what's called a navigation hub, and the reason I'm explaining it to you is because we are changing the way we respond to patients. Um, you said that you're worried that the information will get lost. There's always a risk that information is going to get diluted and lost somewhere, but we do try and record as much as we can on the CAD, so we can't accidentally delete it. But if it gets through to the Brighton hub, as in it's a call for validation, i.e. remote response, we work closely with the hospital as well. So we have a consultant in the hub. Sometimes it's geriatrician, sometimes it's a medical consultant. So we may be getting additional information from them to find out what the correct course of action would be for that particular patient. Doesn't sound like it was such a smooth process for you, but we generally do really well on a weekday. So bear with us. We are trying to get things right, but we do try and obtain the right information from other sources as well to make sure that the patient has the right response. I hope that helps.
Okay, thank you.
Yeah. Um, Wasim, Kate, I'm aware, not that in full detail, but there's been a pilot project in Polegate. Is that something similar to what you're describing with this hub, Wasim?
Yes, it's very similar, except Brighton's still running, whereas Polegate's pared back.
Okay. So it might be worthwhile to have a bit more information about that, Kate, that we can send out if it's
Yeah.
available.
So, as Waz said, our current setup for virtual care is that we complete a triage and a navigation within our EOC, and appropriate patients that could be, signposted elsewhere are picked up by our navigation hubs in Brighton and Polegate, sometimes reassessed, unfortunately, Colin, but for the right reasons. And then, where possible, they work with providers to directly refer through, whereas sometimes you wouldn't believe it, but sometimes we ourselves in CCAM get stuck and are difficult to, refer
Mm.
to same day emergency care, etc. That model will continue to run for probably the next 6 months at least, and we are evolving those, and that's where we're looking at these single frameworks for clinical assessment hubs to have these more flow, one triage built into our process. So all the good work that's been done by Waz and his team and in Brighton and Polegate will be expanded upon. And we have similar models across Surrey and Kent as well, to ensure that we're, as you say, we're virtually responding better,
Mm.
and getting the care and still dispatching, where we need to those life-threatening incidents.
Thank you. Thank you very much. I can't see any other hands, or I'll just check the chat and see if there's anything in the chat. No, I haven't got any question there. So what I was going to just come back to, Kate, and it not a million miles away from what Colin mentioned, the shared records, access to shared records.
Mm.
Kind of what's the progress, or where are we with that?
What a good question. I can't answer 100% honestly. I can only answer by what I know, and that is that there has been an incredible amount of work done by our digital teams and our partnership teams to give us access. As you know, we're a trust that covers multiple systems, and that's where our problem lies, in that all systems use different IT, different models of delivering it. I believe Sussex is Plexus, isn't it, that you use? And we currently don't have that. So there's work ongoing to pilot access to that for initial use. We still are piloting our GP Connect. Within our virtual model, as we expand it, we are looking at all the possibilities that AI can bring us, and also making a big long list of all the digital access that we have and how we can really utilize that and make it better. I unfortunately don't have all the answers, but it is an objective that, as you say, we have available shared care records, and the ICBs are working with us on that as well, in a sense that it is their responsibility that we can all see each other's patient journeys. As you can imagine, this brings IG issues and data protection, etc. So it's a slow progress, but we hope over the next few years to be able to expand on that, deliver more. And that's where possible, having information ready for us that we can't see, that is relevant to the patient and would be relevant to our clinician to assess, is what we'd be grateful for. Say even things like DNA CPR statuses can really change the way a patient is presented to us and what actions we're provided. There's elements within our CAD where we can get that information, but if we have it at the start of the call as soon as possible, as soon as the patient's presented, then we can make those decisions really quickly.
Great, fantastic. Is there any other questions or comments people want to add? Any scenarios that that you found challenging? It's a good opportunity while we've got Kate and Wasim on the call, just to walk through some of those. No? Okay. No, I can't see anything appeared in the chat, Kate. So thank you very much, and Wasim as well. If you can get some information to us about the key care home leads. I don't know whether you all know who your care home leads are in your area, but I will pass them on when Kate sends them to me. This is being recorded, so you will get a copy of the slides Kate presented and the recording to watch again if you want to show it to any of your teams as well, because appreciate as managers, you're not always there in your care setting, so it's around kind of keeping your team upskilled and appraised as well. So please do feel free to share it with them. And if you think of any other questions, do email me, and I can pass them on to Kate or Wasim if necessary. So thank you very much. You have a few minutes back of your time this afternoon, and have a good rest of the day. Thank you very much.
Thanks, everyone. Thanks, Elizabeth. Take care.
Thank you.